Dr. Solomon, you can go
Hello.
ahead and unmute yourself.
Thank you, sir. I have actually connected. Thank you so much, Dr. Bello. Uh, Distinguished colleagues, ladies and gentlemen, I don't think we have so much time to waste. Even though Dr. Teresa Pant is already raising her hands, but we're already on. So it's another special edition today. I don't think there is much to waste without much ado because our international counterparts are already on board. Both the presenters are here present. I can see them in the roll call. But in our normal rituals, we have to start in earnest so that we'll be able to cover a lot of grounds. The normal way it goes is one, we cannot start this interactive international lecture without calling the name of the Almighty God to come and help us to cross-pollinate ideas that will place us in a front burner to offer better pharmaceutical care services to Nigerians and Africans at large, as the ideas are going to come from the foreign counterparts, who invariably are equally our siblings from the United States of America. Ladies and gentlemen, the first point in agenda before protocols will be to do an opening prayer. I don't really know whether my wonderful working able scribe education committee is on board. Dr. Regina Danes, if she's on board, can she lead us in opening prayer so that we can start? Because there is no time. Dr. Regina Danes, are you on board? Hello, can you hear me? Hello? Hello? Hello?
We can hear you, but she is not here.
Okay, she's not here. I don't know whether, because of the sake of time, can I do the justice? Can I do the prayers? Dr. Bell, are you there? Hello, Dr. Bello, our project manager.
Go ahead and pray, please.
Okay.
Yes, I'm there. Please go ahead and pray.
Yeah, pray. In Jesus' name, the mighty name of Jesus. Father, we thank you so much for today. This is the day we have been waiting for. It's really a blessing of the Almighty as it come to a reality. Father, as the technocrats of clinical pharmacy practice in the world, we gather through Zoom meeting today, this night. Give us the enablement to cross-pollinate the ideas that will help us to shake out Nigeria in a green burner that the world will know that we're not rated for things that are evil, but the things that are good, and coming from the angle of pharmacy profession. Almighty Father, may your will be done, as the ideas will be things that will strengthen the board certification of pharmacy practice in Nigeria and the cream content of residency practice. We make this prayer in the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Amen.
So we can quickly start by going gradually on the protocols. First of all, the lead speaker, our own mommy, Dr. Teresa Pants, how we call her name when the time comes, but be that as it may, let me not forget the rituals of the normal way of this clinical presentation. I am welcoming on board, if he is present, the President of Pharmaceutical Society of Nigeria, our brand new president, Professor Cyril Ordiano Seusifo. Prof, and our president, if you're around, you're welcome, sir. We welcome the elders of the profession. I welcome the fellows of PSN. I welcome the fellows of WAPCP. I welcome the national chairman of CPAN, able working chairman, Dr. Joseph Madu. You're welcome, sir. I welcome the fellows of Nigeria Academy of Pharmacists. I welcome the distinguished members of the Council of CPAN, Nigeria and West Africa. I welcome the who is who in clinical practice, pharmacy practice in Nigeria and beyond. Ladies and gentlemen, is another edition that will guide us in the best way to turn the clinical pharmacy practice for us to embellish and be happy. Ladies and gentlemen, permit me to read the little citations which Dr. Teresa Pants will oil as the event unfolds. Dr. Teresa Pants, who is the next person I'm going to call, is our doctor in Nigeria, who is based in the United States of America. Dr. Teresa Pants is an expert in nutritional support. Dr. Teresa Pants is the president of NAPSA. NAPSA is Nigeria Association of Pharmacists and Pharmaceutical Scientists in Americans. She is the president of West African Society of Parenteral and Enteral Nutrition, and equally the founder. She is a consultant clinical pharmacist and a residency program development expert. She's a specialist in metabolic support and medication therapy management. She is going to be the lead speaker of this night's presentation. The other ones I'm going to mention in a jiffy before I'll hand over to Dr. Teresa Pants are: one, the first speaker, Dr. Pamela Moye Dickerson, is a board certified pharmacotherapy specialist, is a member of American HIV Pharmacists. She's a clinical associate professor of pharmacy who is resident and practices and teaches in Mesa University and practices in Atlanta Medical Center, Wester. She's a member of NAPSA. She is a specialist in internal medicine. The second speaker is Dr. Uche. She's a board certified ambulatory care pharmacist. She has masters in education. She's a clinical pharmacist in Neighborhood Health Center, University of Colorado, Scouts College of Pharmacy and Pharmaceutical Sciences. She's a member of NAPSA and a co-chair of monitoring committee. She's a specialist in ambulatory care, more especially in chronic diseases. The last but not the least is Dr. Angela Nuese. She's a board certified pharmacotherapy specialist, a clinical associate professor in Mesa University, College of Pharmacy, and Emory DeKalb Medical Center. She is a member of NAPSA, and she's a specialist in internal medicine. Ladies and gentlemen, we are on, and we are the part at the climax to begin the presentation for me to hand over to our erudite scholar, our mother, Dr. Teresa Pants. But be it known that each presenter is going to spend 10 minutes. Why the people that will do appraisals, contributions, and questions will not spend more than 2 minutes in this, so that we'll be able to carry everybody along and wrap up this lecture to the glory of Almighty God. Ladies and gentlemen, permit me, I am your moderator tonight, Dr. Solomon Kelechi Nwaforo, the National Education Committee Chairman of CPAN International. Ladies and gentlemen, let me quickly hand over the microphone to our erudite scholar, Dr. Teresa I. Pants. Dr. Pants, ma, are you on board?
Yes, I'm on board. Yes. Can everybody hear me?
We can hear you.
Everybody? Okay, very good. Yes. Thank you so much for that wonderful introduction. As always, it's a pleasure to be here talking to my fellow Nigerians on a topic that is really very important. But before I start, you've already introduced the members of the panel, and thank you, you did a great job. I don't really have much to add other than what you've already said. So I'll go ahead and just introduce the topic. We're going to be talking about specialization in pharmacy practice through board certification or residency training in Nigeria. We're actually looking at the purpose of this call today is to kind of review the US model, to learn from our specialists. So pretty much everybody who is here today are specialists. And at the end of this presentation, I think everybody will get a sense of what a specialist actually is from the educational background, starting from the PharmD, then to the residency and to the practice and board certification, which is what we really wanted to get a feel for today. So once that's done, that will probably open up some questions for my audience. I want to make sure that I'm not missing any NAPSA member who is in the audience. I think Dr. Tometi is probably in the audience, so I want to make sure if he's there, I would like to recognize him. And the other point I want to make is everybody else on this team are NAPSA members, starting from Dr. Pamela Moye, Dr. Angela, and Dr. Uche Nuese. So I'll go ahead and get started. So Pam, you're going to be able to move the slides. Let's start with me. A lot of you know me, and thank you for that, again, warm introduction. I've been coming to Nigeria for years. Obviously, I have a Doctor of Pharmacy degree from Mercer University. Then, of course, I did my PGY1, which is the general residency, then ended up doing a special a PGY2, and I specialized in critical care nutrition support. So a lot of my years of practice has been in the nutrition support arena, also with the residency program, directing the residency program. Next slide, Pam. I think you also mentioned, because of my interest in nutrition support and because of what I saw coming to Nigeria all these years, it was really clear that there was opportunity when it comes to malnutrition, that the incidence of malnutrition is probably not well captured, and that the awareness, which is actually the key thing of malnutrition in Nigeria, even in Africa, and that's why I named it WASPEN, because I'm just not looking at Nigeria, I'm also looking at in Africa. So I'm the president and the founder of WASPEN, and really have up to close to 100 members in that organization. It's a multidisciplinary team committee, and doing a lot of things ranging from webinars, education, and so on and so forth. At some point, probably you guys will hear more about that. So prior to me really focusing on the consultancy part of clinical pharmacy practice and residency program development, I would like to speak briefly about what I did in a particular institution, which is Wellstar Healthcare System, Atlanta Medical Center, and you're going to hear more from Dr. Pamela Moye. I was the clinical pharmacy manager, meaning I was administrative managing the clinical pharmacy programs from pharmacokinetics, nutrition support, anticoagulation, the pharmacy and therapeutics committee, and then I did a lot with precepting pharmacy students. And in addition to that, I was the residency program director, the PGY1 residency program director. So it was during the course of that I collaborated with pharmacy schools, and through my collaboration with the pharmacy school, I was able to bring in a specialist in internal medicine, and you're going to hear from her shortly after I finish this. So what I'm currently doing is consulting in what I practiced for almost 15 plus years. Yeah? So now I'm consulting in clinical pharmacy practice and residency program development. And of course, I'm the president of NAPSA. So what I would like to do at this point, because I would like to just see what questions will come up at the end. I don't want to take too much time. I think I would like to hand over now to Dr. Pamela Moye, which you guys also have had the pleasure of meeting. She has done a lot of clinical programs with me in Nigeria. And the first one she did was actually the clinical pharmacy program that our current president of PSN, Dr. Cyril Osufo, was the one that actually came to me and said, listen, there is a need for this to be done. And that's when we did the first pharmacotherapy workshop in Nigeria through the help and leadership of also Dr. Enato. And then, of course, Dr. Angela was also part of that. So now let me hand over. So Dr. Pamela Moye, I'm going to hand over to you now and have you tell them about what you do, your background, and so on and so forth. Thank you. Dr. Moye.
Thank you, Dr. Pounds. Before I begin, I would also like to say, with Dr. Pounds and her collaboration with Mercer, not only was she able to bring in a specialist like me for internal medicine, but she also brought in a specialist for critical care, a specialist for infectious diseases, and a specialist for ambulatory care. So it wasn't a small feat, it was a big thing that and it helped progress along the clinical pharmacy program and the residency program. So through her leadership, we were able to actually become one of the sought after programs in the city. So I thank Dr. Pounds for that. And also with me going to Nigeria, it was introduced in 2012. I guess 7 out of the last 9 years, I've gone to Nigeria for either a preceptor development program or to help with this PharmD conversion program. And we've done anywhere from the north in Jos to Benin City. So I'm happy to have been a part of that. Okay, so like the moderator said, I did get my PharmD. I am a PharmD, and I got it the traditional way at University of Georgia in Athens, Georgia. I did a PGY1 at Duke University in North Carolina, a PGY2 at Virginia Commonwealth University in Richmond, Virginia. Immediately after my PGY2, I then accepted a faculty position at Mercer University, but part of that faculty position was also the me being brought to a practice site, which is where I met Dr. Pounds during my interview for my job at Mercer. And I can always say the rest is history after that. I am board certified in pharmacotherapy from the Board of Pharmaceutical Specialties. And I also have an added qualification from the American Academy of HIV Medicine certified as an HIV pharmacist as well. To orient you to the hospital where I practice, so it is a 460-bed tertiary center, level 1 trauma center. We do have a level 3 neonatal center. It is a teaching hospital, so we do train physicians, and so we have our own graduate medical education department, and we do open heart surgeries, strokes. So we do have a cath lab. And I like to say this because it's important, because it helps with training, not only for you practicing as a specialist, but also training students and training residents, having being a part of an institution that have a variety of specialties and already training other healthcare professionals. Part of my service, there are 3 teaching teams. We're part of the graduate medical education department and 3 internal medicine teaching teams. And I usually take care, I'm around with one, and then I kind of profile manage another. About each team has about 14 patients per load. We're on call every 4 days. So short call, meaning during the day, any new patients admitted to the hospital will be admitted to your service if you're on call. And then long call, of course, is the overnight call. The team usually have 1 attending physician, 1 attending pharmacist, which is me, 1 or 2 medical residents, whether it be PGY2s or PGY3s, 1 or 2 medical interns, 1 or 2 medical students, and usually they're 3rd or 4th year students, and then 1 or 2 pharmacy students. And all the pharmacy students will be in their 4th year or their last year, they're on their rotations. And to the right is a typical day So we pre-round, meaning we work our patients up. I have my students and my residents and myself. We work the patients up that we're going to be rounding on. I usually only give students about 4 patients to work up, but the resident, if it's a resident, they work up all the patients, and of course I work up all of the patients. Rounds tend to be for the rest of the morning, 9:30 to about 12:30, about 3 hours of rounds. If it's a heavy day or a post-call day, rounds could last a little bit longer. And then on those rounds is where I make my recommendations, right? So we work patients up, then the students and the residents run patients by me with recommendations they want to make. I either approve or deny the recommendation for the student or the resident to make. And then we go on rounds with the docs, and then we make our recommendations. Generally, I tell them kind of like a hierarchy. You don't really want the medical residents to feel any sort of way, right? So generally, we make our recommendations first to the medical residents, and depending on the attendings. So some of my attendings, they like to have sit down rounds where we're all sitting down at the same time and we just make the recommendations there. But if it's one that we won't have a formal sit down rounds before we go to the patient's rooms, then we'll make the recommendations to the residents. And then if the recommendation isn't made or isn't accepted, depending on what it is, then, but usually if it's not accepted, it's usually a good reason. We kind of talk it through. That's the other good thing about being at a teaching hospital. We talk through recommendations, and I may think it's a good one from a pharmacist's perspective, but the physician may see something that I didn't notice as a pharmacist. So, but it's a really, really good learning environment for residents and students. And I'm really, really thankful for that. And Dr. Pounds has a lot to do with that type of the relationship that we're able to have with the physicians and other healthcare professionals in the hospital. Then after rounds, it's 12:30 until is whatever. So it could be staff development where we're giving presentations to the pharmacy staff, medical staff, nursing staff. It could be topic discussions with the residents and the students, any type of meetings or any clinical initiatives that we need to move forward with the hospital. It kind of varies. And then patient follow-up. So that's when we'll go back to the patient's rooms if we need to do med recs or medication reconciliations or medication histories, counseling, patient education counseling, if we need to call insurance companies, or work with our ambulatory care clinic to see if we can communicate with that pharmacist there for patients who are going to be seen after that. And this is just a schematic, like a table of some of the interventions, types of interventions that I make monthly. You know, most of it, of course, is more like ADR identification, whether it be before it happens or because it happens. And then the next highest is dose optimization, and it's usually has to do with renal adjustment, or it could be timing. We know, as pharmacists, this is what we do, and they may not necessarily know the appropriate timing for some of the meds. And then the third highest is drug information, and which we answer a lot of. I always say we're a walking, talking drug information resource. And other things that I do as a specialist or faculty at a hospital, I, of course, research. Right now, we're wrapping up our COVID-19 research, and this is actually a sub-project that I found was interesting. The data was found on our larger project that we did. Where we're looking at the impact of COVID-19 on African-American men, because unfortunately, we do in the States, we do worse when we're admitted to the hospital as a community, and then especially our men. And so I wanted to kind of identify things that are going to put characteristics that put those men at risk for dying of COVID if they're hospitalized. And then future, I'm working on transitions of care. It's another little love of mine. I like transitions of care. I've already implemented a transitions of care APPE, or rotation clerkship for my students. We don't really have a transitions of care pharmacist at the hospital just yet, so I don't really have an elective for a resident, but I'm using the data that I'm collecting for my student to help with the SBAR for bringing a transition of care pharmacist on. And then my other topic with transitions of care is kind of enhancing the communication. Once the patients get discharged from the hospital and they're out in the community, I think that communication portion is where in the States we can do a better job and where we kind of drop the ball a lot. And so I want to develop a project where we can improve the communication. And the services provided, I guess, things that I talked about already with the clinical services, PGY1 support. The hospital doesn't pay me. So potentially there's financial benefit for me being there because of the fact that they don't pay me, but I do provide a service for them. And it's cost avoidance typically, right? So it's not really hard dollars. Oh, and that's it for me. And so next is Dr. Nuese.
Mm-hmm. Thank you very much.
I would like to say one or two words before Dr. Nuese. Dr. Nuese was also one of the original clinical specialists who came with me to Nigeria for the pharmacotherapy workshop. So I really want to recognize that for all the great support and all the great accomplishment of really being part of developing clinical pharmacy program in Nigeria. So Dr. Nuese, and she's also from Nigeria, and her husband is from Delta State. So
thank you very much, Dr. Pounds, and thank you also for the opportunity to have been involved early on with just initiatives in Nigeria. Like Dr. Pounds, I'm Nigerian, and so for me, it was just exciting to have to go back, and I got to see my family too going back each time, but also getting to give back, doing something that I enjoy doing. And so I did grow up in Lagos State, and actually I went to Unilag for a year before transferring over to Long Island University to complete my PharmD degree. I'll say during school, I developed a love for clinical pharmacy. And so for me, it was a natural progression to go on to do a PGY1 residency. And then after that, I already knew before PGY1, I wanted to specialize. And so for me, internal medicine was kind of a natural progression because it's a little bit about everything. And so it helped to develop my clinical confidence, getting to practice in that area. I would say my preceptors that I worked with, they were all board certified, and I saw them practicing at the top of their license. And so for me also, that was a natural progression to get board certification. So I went ahead and earned that right after my PGY2 before things got really busy. And so, I then moved on to Mercer University, kind of got the board certification shortly after joining Mercer as a clinical faculty member. And so my current role, similar to Pam, I'm also an internal medicine specialist. And so I teach students at Mercer, but I also practice at my practice site, which is Emory Decatur Hospital. I teach students there as well as provide service to the hospital. And so similar to Wellstar, we are a community hospital. We're a 451-bed community hospital. We're not a trauma center, but we do have a level 3 neonatal unit. And we provide general medicine services like nights in a community hospital. So we also have a cath lab. We provide specialized cancer care, women and infant services, and we have a weight loss center. We're not a formal teaching hospital whereby we don't run a medical residency program. But before we became part of the Emory healthcare system, which is a larger healthcare system, we used to have medical students and medical residents from other medical schools. But currently, running out of Emory Decatur Hospital, we do have a podiatry surgery residency program as well as a pharmacy residency program. I mention that because these are some of the folks that we can also collaborate with as well. And so going over to the internal medicine service and kind of our role of the team, again, before we became part of the bigger Emory healthcare system, when we had medical students and medical residents rounding with us, we were able to develop an interdisciplinary team where we, incorporating our attending physicians. All of our physicians are fully licensed. And so we have, so in addition to the trainees, we also have the attending physicians. I rounded with the team as the attending pharmacist. We also had the medical students, medical residents with us, as well as a podiatry resident, and then also medical and pharmacy students. Because we had these variety of learners, I was able to develop interprofessional education amongst these learners, which was pretty unique and pretty rich. When we became part of Emory healthcare system a few years ago, we were not able to hold on to the medical students and residents from other medical programs that were not part of Emory. And so we kind of lost those learners. However, we were able to have a more intimate interaction with the team, whereby right now we round directly with the attending physician, I as the attending pharmacist, and then with the pharmacy students. And so we have a richer experience, direct experience with the physician team members. I would say it helps us to build the students' communication skills with the team, the relationship with the team. And when we have, recommendations for the physician, because we've built that more intimate collaboration and relationship with them, we're able to have more direct interactions with them as well. Sometimes our rounds are sit-down rounds. Sometimes the physician goes up to the floor and we get to round and do more bedside rounds. So in terms of typical day, my day at the site with my students, I have my students work up the patients. They work up just a few patients on the team. We may have about 10 to 15 patients on one hospitalist team. And so the students round on the patients, and then I round with the students, present the patients to me, any concerns they have, any recommendations that they have. And then we round with the physician. Rounds are about an hour to an hour and a half. And then we follow up on any points on the patient, if it's educating the patient, completing medication history, helping them with access to their medications. And then I sit down with the students and do topic discussions. And so we discuss, maybe disease states that the patient has had. About 1 to 2 times a week, we have kind of formal topic discussions, as well as just patient presentations, informal case presentations as well. So I wanted to also discuss some of our interprofessional collaborations with team members, and in addition to services that we provide as a collaborative member of the team. And so we do medication history and reconciliation. I would say that I feel this is a huge part of where we contribute to the care of our patients and kind of fill a gap in the care of our patients. Nurses ideally perform med histories, but sometimes it's not always able to be performed at the time of patient admission. The patient might be confused. The patient may not know their meds. It might not be a good time to get the med history. And so in all of the patients that we see on the team, we go ahead and do a medication history from the patient. We call their pharmacy, call their caregivers. And I would say that it's helped us identify, potential interventions. Sometimes we identify medications that may have led to the patient's admission. Sometimes we identify medications that, we're duplicating inpatient. We did not know they were already on oral anticoagulation. We put them on a new one. And so we do help to catch some potential gaps in the patient's care. Also helps us make sure that we continue, key meds that they need to continue. In that regard, we collaborate with nurses because we help, we help perform activities that can help them, that can help take that off their plate. We collaborate with physicians, letting them know the med histories and potential changes to inpatient meds, as well as other allied health professionals. Sometimes when we do medication histories, we identify that patients are not as knowledgeable about their meds, and so they need education. Sometimes patients have problems accessing their medications, and so sometimes they can't afford their medications. And so part of what we do is also helping patients with access to their medications, access to free clinics, access to patient assistance programs. And so those are some of the items that we collaborate with patients on, educating them, collaborate with case managers, social workers, other allied health professionals. Other ways in which we collaborate with the team, just doing daily medication review, we get to circle back to the physician and talk to them about, sometimes we, like Pam said, we think we have a great plan, but physicians might have their own perspectives. And so I usually tell my students, even if something looks off, you never approach it to the physician saying, you did not do this, or this should be done. You more so clarify, I noticed this, wondering if there's a reason for this. What are your thoughts with this? And so you're always thinking about ways to maintain your relationship, and also thinking about it's all for the patient, right? It's not about me or the physician, it's all about the patient. We also collaborate on research projects. And so like Pam, a passion of mine is also transitions of care, because that's an area that we see a lot of gaps in care. And so we collaborate. I've done projects with nurses, physicians, the quality assurance team, just helping to fill those voids in care. I've also collaborated with other specialist pharmacists. I do not deal with neonates, but a project came up in that area. And so got to collaborate and do a project with my students in that area. Also, when you build relationship with physicians, they also want their name out there. And so they know I like to publish. And so they usually ask, hey, would you like to write up this case report? And I'm always excited to jump on that as well. Also, we help with nursing and staff education, as well as transitions of care services. Also for me, interprofessional education is a big passion of mine. And so because I also think about, okay, we have nursing students from Mercer on site, we have pharmacy students on site. And so I collaborate with our nursing faculty in order to set up that experience, as well as with our physician team members as well. In that regard, I've also done educational projects as well. I love this cartoon because it says, how do you want them to work together if they don't learn together? I think kind of the roots of interprofessional collaboration is really starting off having these learners learn together before they get out into practice. And kind of wrapping up, similar to Pam, I just wanted to share some of the impact that we have on the team with our students. So this is just in a 5-week appy, just kind of seeing where are some of the ways in which we intervene in patients' care. I would say a huge part for us is filling that gap with medication history and some of the trickle-down effects that it has as well. Also just avoiding therapeutic duplicates, helping to educate our patients, lab evaluation, as well as recommendations to optimize patients' care. Sometimes it's, medications may not be needed. We may have additional meds that needs to be discontinued. So this is just, a 5-week period in which we captured just 2 students doing their appies with me, just captured interventions. We try to collect it through the year and just show the value that we provide as clinical pharmacists to the team, but also a bigger portion for me as well is the value that our students also provide as part of their learning. And so I think as we get specialized, as we get confident and comfortable in our practice, it's always good to help train students to also see how they can make an impact early on in the care of their patients. And so I'm going to pass it on to Dr. Uche to share more about her background and her practice.
Yeah, just 1 minute. Let me just say a little something about Dr. Nuese. Dr. Nuese and I go back again. As one thing you always notice is, I've worked with this wonderful clinical specialist, but one thing with Dr. Nuese is that she worked very closely with me on the NAPSA Educational Committee, worked well in terms of helping me develop that committee. And now she's also helping co-chair a mentoring committee. She's also from Nigeria, and I'm sure she's going to share that. So I think I just really wanted to make sure that you all know the value of Dr. Nuese, not only what she's brought to NAPSA, but also what she's brought to the advancement of clinical pharmacy. So Dr. Nuese.
Good afternoon, everyone. Can you hear me okay?
Yeah. Mm-hmm.
All right. So yes, my name is Uche Nuese, and thank you so much for that wonderful introduction to PAUNS. I'd like to recognize everyone. I am a hybrid. I did my first pharmacy degree in University of Benin, Great Uniben, and then I did the non-traditional pathway to get the PharmD from the University of Colorado. And so sometimes I do feel like I have an identity crisis. I don't know from to burn. And that has gotten me involved in NAPSA, helping out with things that I'm passionate about while I maintain my job. I did my PGY1 training at Providence Portland Medical Center. PGY1 stands for Postgraduate Year 1. So it's a 12-month training at this site. And then I did my PGY2, which is Postgraduate Year 2 training at Care Oregon, which is actually a health insurance or health plan for underserved population in Oregon. I am board certified in ambulatory care pharmacy. I'm also board certified in advanced diabetes management. I have certificate in diabetes education, diabetes support, and I'm currently practicing at Neighborhood Health Center at the Milwaukee Clinic here in Oregon, USA. Next slide. I'd like to take a different approach to this topic. My colleagues have shared what their practice, what their practice is like. I'll touch upon that a little bit, but I wanted to just tell you a bit about my journey and what it takes to be board certified or how I got to where I am. like I said, I did my first degree in pharmacy in University of Benin, and I did the non-traditional PharmD program at University of Colorado. The curriculum consisted of didactic training, which I did by long distance. And this is a special program that they designed for pharmacists who are already graduated with a bachelor's and are currently licensed in the United States. And then they had 1,600 hours of experiential learning, meaning I had to spend time in inpatient care, ambulatory care, drug information, and then I had to do electives, all of which totaled up to 1,600 hours. I bring this up because I think that is crucial in our understanding what it takes to get to where you can comfortably practice as a clinical pharmacist and get board certified. One of the things I want to highlight about the training that I got from University of Colorado is two things. One is they spent about 3 credit hours teaching us about evidence-based medicine, how to search for information, how to deliver information, how to understand the evidence. And they also, I think I took about 2 credits, 2 or 3 credits on instructional methods, which I think for me was a game changer for my approach to pharmacy practice. And instructional methods just teaches you how to provide instruction and how to teach. And I think for me, that gave birth to a lot of things that I started doing after that I graduated from pharmacy. Slide. So this is what my PGY1 training was, a year-long training in a 500-bed hospital here in Oregon. And I had 6 weeks rotations in each of these sites, inpatient in internal medicine, cardiology, and infectious disease. And I also had 6 weeks rotations, each in primary care or family medicine and in geriatric. One of the things I liked about the training was that it laced us 12 months with teachings or experiences in pharmacy management, leadership projects, and it also gave us an opportunity to get a teaching certificate. So that also helped to further develop what the 3 credits that I got from University of Colorado in instructional methods. And next slide. My PGY2 training was a bit atypical, not a typical kind of training that you have for second year, because a lot of the PGY2 delves deeper into the clinical practice in ambulatory care. Mine was a little different. I am very thankful for that. So this was a PGY2 that was designed from a health plan. So this health plan was to cater for indigent patients, Medicaid, people who couldn't afford a lot of money and their health care was suffering. And so they wanted to find out why some of them were frequently visiting the emergency room and frequently being hospitalized. For in the US, we have this idea that frequent hospitalization and frequent ED visits are the drivers of healthcare costs. And so this health insurance was wanting to curb that for their patient. And so the director had this great idea that if they had pharmacists, unleashed pharmacists to these clinics, that they will be able to find out something, why these patients are frequently going to the emergency room or are frequently being hospitalized. And true enough, we did find some of those issues. However, the approach we had was to go into these clinics. So these are primary care clinics, the same way you would have clinics in Nigeria, like in Federal Medical Center or community health care centers. That's how these clinics are here in the United States. So the patients are usually underserved, low literacy. And so what we're tasked with was go in these places and find where pharmacy can be of service. And so we went there with a service-oriented attitude, wanting to find out how best can we serve them. We had a blank plate. We had ideas of what we could do, but we didn't push it on them. We just, where can we best serve you? And I spent about first 2 or 3 months just observing patients, observing workflows, observing providers, and then coming up with a plan of what to do. So that's essentially what I did. And I assessed workflows for medication use problems, and then did a bit of more population health, where I looked at the frequent users and see their activities and see why they were having the problems they were having. And Next slide. Based on this, I was able to now get integrated into Neighborhood Health Center. I was the first pharmacist to be hired there based on the work that I did in my PGY2. And based on that work, we found out the buckets of things that we needed to do would be, first of all, the medication reviews were the most needed. Things like medication reconciliation. What does a patient take? What are they supposed to be taking? Are they actually taking? And then doing comprehensive medication reviews. Are the medications appropriate? Do they need more? Do they need less? Are they drug interactions? And so those are the first things. I think that when in my observation, the medication reconciliation bit was the most needed. And even though it was what we called not appropriate for a full-fledged pharmacist, but some etap to come because we wanted to gain access into the rest of medication use system. Based on this, we also found out that they had their diabetic patients were all poorly controlled. Their hypertensive patients were all poorly controlled. So we're able to write up a collaborative practice agreement. Collaborative practice agreement is where you agree, have a legal document that allows you to manage certain disease conditions. And so in that collaborative practice agreement, you write prescriptions, you order labs, you refer patients to specialists or refer for further investigation. All of this is under your purview. And so based on our work, we're able to have collaborative drug therapy management for chronic diseases like diabetes, high blood pressure, cholesterol, COPD, asthma, smoking cessation. We have written more protocols for depression, obesity, which we are hoping to enact in the near future. I know that when I discuss with some pharmacists back home, they say, so if you do all this, what does the doctor do? We do believe that we have a large population of patients and there's not enough time for the doctors to spend on each patient. So while we are doing this chronic disease management, they are doing some acute care concerns. They are also looking we are working collaboratively, so we are both giving our insight and our perspective to this particular patient. Our patients are a lot healthier. Like when I see patients, I'm looking at their adherence. When was the last time you took your medication? I check pharmacy field history. The doctors don't have time to do that. So I do all that work for them. And that makes things also understand exactly where the patient is and what is going on, and if they're not taking their medication and why. I spend more time in education because a lot of you have to get the patients buy-in to be able to get the therapeutic outcomes that we want. And so it's worked well. A lot of the doctors are quite grateful for what we are able to achieve together. The last bucket of things that we found that we could do in this ambulatory care side, so this is an outpatient clinic, like I said, is education. So I provide a lot of drug information. Every day I field about 3 to 4 drug information questions. Because we have an influx of a high turnaround of doctors that come in and go, we see the need to maintain our presence, to make sure that if you're new, you know that pharmacists are here, the pharmacists are available, and they are providing good service. So we do newsletter articles, and these newsletter articles are called it the biweekly dose, which I actually edit. And we send it out to them. It's information about anything whatsoever. From like this week, I'm writing on when to use GFR and when to use creatinine clearance for drug dosing. Last week, we talked about the use of natural medicine for cholesterol. Sometimes we do a patient case presentation. So we've used it to maintain presence, like we are here. Even if you've never worked with a pharmacist, know that these people are here. And then precepting is another thing I do, just because I guess I love teaching. But the other thing is that we have a part of a lot of opportunities to share with students who are coming along of how pharmacy practice can be in ambulatory care settings. The other thing is, because of COVID, we have not been able to provide what I call a healthy experience in ambulatory care for pharmacy students. As a result, I developed a drug information rotation, which is an online rotation. And this has been a unique opportunity for a lot of students who are not able to be here face to face. So it's a remote learning, but they have they do projects. They are the ones that actually write these newsletters. edit them. They do formulary reviews. We do journal club every week. And it has been one of the richest experiences that I've had in the past 2 years since COVID started. Next slide. My typical work day starts by 8 o'clock. So the first 15 minutes, I do what I call a powwow. I talk to the medical assistants. We look at the schedule, see what patients need. Some patients need extra reminders to make sure they come to the clinic. Some patients need extra reminders to make sure that when they come, they bring their blood pressure machine so that we can calibrate it, or bring their blood sugar machine so that we can look into it. Some, they're just different needs. Who needs labs? And because of COVID, we've been short-staffed a lot. So figuring out what the support staff need so that I can accommodate them. Then from the first 4 hours is patient care. I'm just seeing patients every 30 minutes. And then the last bit of the day is patient care and meeting doctors, depending on what is blocked off. I do have bi-weekly meeting with the doctors. Every 2 weeks, we have one and a half hours meeting. We are reviewing what is going on well, what is not going on well. And I give them updates on formulary changes. I give them updates on guidelines. In fact, this week, I noticed that there's been a lack of consensus on the use of phentermine for loss. And different providers said yes, some say no. So my next task is to talk to them, and we all review the evidence for the use of in weight loss, and we come to a consensus as to what the practice should be. Next slide. And so this is my final slide, and I just want to say that just because like I said, I have identity crisis, I understand what going on back at home. My take-home message, and I think if you listen to all that we have said so far, is what is most needed is us having a service leadership attitude. So you know what you want to do, you come as a servant. One of the things that one of my bosses taught me was, when you go in there, Uche, just make sure you go there as an anthropologist. I never knew that pharmacists could work as anthropologists. And what we go there is just go there and find out what is the need, what is needed for the journey. I'm not going there to impose myself. I'm just, what is need? What do you need? And people usually respond to, what do you need to help you today? And then start with low-hanging fruits. I think for me, that's what made us successful at our clinics. The MedRec, even though I remember going back to my boss and saying, no, MedRec is what they want us to do. He said, but MedRec has very little return on investment. I'm like, but that's what they want us to do. And he had to agree, because he had told me to go in there with the mind of an anthropologist. So we started with MedRec, and then drug information. And that was what gave us we've been here for, I've been here for 6 years now. We've hired, after they hired me, they've hired about 6 more pharmacists. So we've grown. We've been responsible for a lot of changes and a lot of improvement in patient care, most of which are quantifiable. Thank you so much for your time and for listening. And then we are open to questions now.
Thank you so much, Dr. Choma. The last speaker is a wonderful one, and all other respected speakers like Dr. Angela Nuese. I know she was Dr. Angela Shabon before.
That's correct.
It's good meeting you again, because I know we had a contact interactions in 2013 University of Benin, where I had an interactive session on the US Consortium, where I met you and met Professor Uche Nadu, which is not present in this relationship tonight. And Dr. Pamela Moye, I must say that you people have actually done wonderfully well this night. And the lead speaker, who is actually the leader of this group, Dr. Teresa Pancha, has always been there for us. She loves her country so much that she's doing everything within her powers to make sure that the best practice is actually embedded and embossed in Nigeria. At this juncture, I cannot stop not to recognize some other people in our midst, like the physicians we have present, like the surgeons. We are so much delighted to have you people in our midst. the nurses that are here present, the physiotherapists, the optometrists, the medical lab scientists, the radiographers. We are so much happy that you are participating in this lecture, this presentation. This is actually trying to bring best to Nigeria, principally the Africa, for us to know there is better way for us to offer services to our patients through teamwork. And I cannot stop in that way without recognizing Dr. Tometi. You're welcome, sir. Professor Wesin, the former SG of West African Postgraduate, you're welcome. My precious HOD, Dr. Mrs. Maureen Eberemosu, you're welcome to this presentation. I equally welcome my IPCC, Dr. Timi Pre Ao, to this presentation, and my airborne national scribe of CPAN, Dr. Motihatu Lulawal. You're welcome. Professor Kwe from UNN and Dr. Isa from UNN, you're welcome. Dr. Kensley Nalue from Federal Ministry of Health, Abuja, you're welcome. Professor Ria Ozolwa, our wonderful guest, who has always been there for us, you're highly welcome. And all other people, numerous, that I cannot mention this night. It has been wonderful meeting and interacting and cross-pollinating the ideas with the Western Consortium in Nigeria for this great lecture. At this juncture, I will call on our national chairman, Dr. Joseph Madu, to do a appraisal why the questions and answers and contributions and appraisal as follows. Dr. Joseph Madu, are you in the house, sir?
Yes, I'm with you. Good evening, everyone. Please, am I audible enough?
Yes.
All right. Let me use this opportunity to once again thank Dr. Teresa Pams for all she has been doing. I feel even though this is an international meeting and we are talking on Zoom, but I feel as if we are all in Nigeria. And let me welcome Dr. Pamela, Dr. Wizuru, and her other colleague, Shogbola, or whatever is her name. Please, you are all welcome. Let me say you're welcome to Nigeria. You're welcome to Nigeria, even though technology has made it so nice for all of us to be together in form of home away from home. Actually, the topic of tonight's discussion or meeting is all about adapting the US model of specialization in pharmacy. And we are very happy that different specialists, those in internal medicine, those in ambulatory care, nutrition management, and the rest of them, we have had different speakers tonight. It has been a very wonderful presentation or discussion. I know that the next clinical meeting by CPAN, we're expecting the chairman of US Board of Pharmacy Specialties, Dr. Brian, will be talking to us at the next special edition of CPAN clinical meeting. So I want to welcome all of you. I have learned a lot this night, listening to you on what you do as clinical pharmacists. Of course, that is where we are going to in Nigeria. Though something has been troubling me, here in Nigeria, we talk of academic pharmacists. We talk of hospital pharmacists. A lot of time you discover that they are not both interrelated. Those in academia, you hardly find them in the hospitals. And those in the hospitals, you hardly find them in the academia. But here are pharmacists who are clinicians who are in the hospital telling us about students. In fact, most of you tonight with the title of associate professors, I begin to wonder, are you academic pharmacists or your hospital pharmacists? In Nigeria, either you leave the hospital, you now go into academia before you become a professor. But that's a topic for another day. Let me use this opportunity to once again thank all of you for coming to enlighten us. And as we kickstart the formation of specialty groups or areas of specialization through the CPAN pool of experts, I know that Dr. Pamela is one of us in CPAN pool of experts with Dr. Tometi and Dr. Teresa Pams. I also want to welcome the other to my sister, Dr. Uche and Dr. Nuese or so. Please pardon me for the pronunciation of your name. Don't worry, we are going to be closer after tonight. So as we kickstart the new specialty groups in Nigeria, because we have started rudimentarily, we want to welcome all of you, those in ambulatory care, those in internal medicine, or those in cardiology. We know we have a lot of you in NAMSA. You join us, and please, you help us to build, to get to the center of excellence. That is the way it is being practiced in the US, because we know that is where we are heading to. I want to thank all of you once more this night. And after tonight, I know I shall be adding those of you who are not in CPAN pool of experts to be members, so that we can always interact, and you will continue to lead us, even though as your Board of Pharmacy Specialties Chairman, Dr. Brian will be talking to us next month. Once again, thank you very much. God bless you. We appreciate. Thanks.
Thank you so much. Our corrugated, our corrosive, and ever ready national chairman. He's always there.
Yes.
He always working around the clock to make sure that things are done well in CPAN. For the short while he has been there, he has a robust stewardship. Thank you so much, sir. Thank you so much. We are so much happy having you as our pioneer national chairman. Then before we continue with questions and appraisals, and before I will still hand over the microphone to our general mother here, the lover of clinical pharmacy practice in Nigeria and beyond, Dr. Teresa Pants, there is a short video. I don't know whether our project manager or our PRO is in the house, Dr. Ibrahim Bello, to play that video, just like something like an interlude, a suspense, so that we're able to rehydrate some other sense of humor within ourselves for this presentation to continue. Dr. Bello, are you in the house, sir?
Okay, yes, can Dr. Prince stop sharing the slides, please? Can you stop sharing the slide? Yes.
Oh,
please.
That's, I think it's Moye, right, Pam?
Okay, okay. Can you stop sharing your slides?
What? I'm sorry.
No, yeah, he wants you to stop sharing the slides. He
Oh,
wants
sorry.
Thank you.
I think Maureen and two people have their hands up.
Hello everyone, my name is Richard Osaiwo, one of the directors. BioWell as a brand was created primarily to be at the forefront of providing general wellness solutions in the forms of preventive care, augmentation of existing primary care, and outright solutions to major wellness needs using almost entirely natural ingredients.
Okay, thank you, Sulman. That's all.
Thank you so much, Dr. Hello. Yes, I can hear you. I'm online. I'm online. After the commercials, in further things, you contact our national scribe, Dr. Motihatu Lulawal, for further explanations and thereabout from that short interlude that you brought in to make us much happier. Before I hand over the microphone to Dr. Teresa Pant for some other information and thereabout. I don't know whether there is any physician or surgeon in the house. Whether there is any physician or surgeon in the house so that you can comment. Or there is any nurse in the house. Or any other healthcare professional in the house. So that let us share their own ideas from these wonderful ideas, cross-pollinations. Is there anybody in the house from other sister professions? Any other person? Any person on board from medicine, like physician, surgeon, nurse, physiotherapist, radiographer, medical lab scientist? Any person in the house? Okay, in absence of them, or maybe they are not disposed to talk presently. I know Dr. Maureen Wafo, our national vice president, has been raising her hands, but I want to do it this way so that we can quickly, we can do it systematically in organized fashion. I will hand over the microphone to Dr. Teresa Pans to do the necessary handling of other things, like questions and accommodation that will come alongside, so that we'll wrap up the presentations and retire for the day. Dr. Pansma, can you take over?
Yes, I've taken over, but I would like to give Dr. Maureen Wafo just a little time to ask her question. I think she's the only one that I see who has her hand up. So Dr. Wafo, Maureen Wafo, do you please go ahead and ask your question?
Good evening, everybody. I hope you're hearing me. Hello.
Yeah. Hello.
Good evening, everybody. Good evening. I'm glad that this topic is being handled today and I've been organized by CPAN. So I want to thank CPAN for organizing this program tonight. And also I want to thank our mommy over there, my mentor, Dr. Teresa Pans. Continue the good work. God will surely bless you, ma. And we pray that in no future time, pharmacy practice in Nigeria will be just like as it is over there. I thank your other team members, Dr. Nuese and Dr. Mowe and the other pharmacists too. Thank you very much for bringing out your time. I have few concerns, questions I want to share. The first one is it possible to adopt USA residency model here in Nigeria, considering PGY1 and PGY2, including the board certification? I know here in Nigeria, we have our West African Postgraduate College of Pharmacy residency program. And I want to ask, can we say that what we are doing in our postgraduate College of Pharmacy here in Nigeria, are they the same with what is happening over there? Is there any way that we are going to integrate the two, that's the PGY1, PGY2, as you are doing over there, to our own West African Postgraduate College? Are they two different programs altogether? Okay. Hello?
Yeah, I can hear you. Yeah.
Okay, are there two different programs that cannot be merged together? That's one. Two, I found out that some hospitals over there do PGY1 alone without PGY2. Is it hospital-based? So I want to understand, is it just one hospital will do PGY1 and the other one PGY2? Can one hospital handle the two? Are there criteria for hospital to handle such residency program? Because our main aim here in Nigeria now is to adopt such here in Nigeria. So I want it to be clarified too. Then I know some of us here over here are quite specialists in some fields of pharmacy practice. They have the skills, they have the training, but without board certification. Is there anything you can help us do to get board certified for such pharmacists who are really practicing as specialists down here in Nigeria? Thank you very much, man.
Yeah, very good. Those are very good questions, and I'll go ahead and take that in addition to some other points I want to make. First of all, let me start with the West African, the fellowship program that you currently have in Nigeria. Luckily, you're the leadership team of that organization, the college. They've recognized that it's a good program, but there is it's lacking the pharmacy practice exposure. Now, the residency here in US focuses a lot on the pharmacy practice, all right? So in my discussion with them, because I've been talking to them for the past, going to like a year or two now, I think there's a lot of noise in the background, please. Yeah. So they've realized that it's now time for them to address this. I'm currently on the credentialing board for ASHP, you know, that governs all the residency program here in US. And because of my being appointed to be on that board, I took that opportunity and then connected the West African group, I mean the college group, with ASHP. And we've been in discussion for the past 1 year. And what is going to happen is we will incorporate the PGY1 guidelines into what the West African is doing, into the part 1. So in other words, the part 1 is going to become a combination of some kind of preparation for part 2. And that's going to have a lot of what is needed practice-wise to get them ready for part 2. Then in part 2 is where we're going to have the PGY1 and the PGY2. I hope it makes sense what I'm trying to say. Now, the West African, you all have the part 1 and you have the part 2. So what's going to happen is the part 1, we will incorporate the pharmacy practice component that was not there before to get that student ready to go into part 2. And then in part 2, that's where we're going to have what we traditionally do here, part 1, I mean, as the PGY1. So that will be the PGY1 and PGY2. Now, that is in the works. They have a very aggressive timeline. Of course, they have to pilot this to make sure they work out all the kinks. They've identified 2 institutions that they're wanting to pilot this, and that's all I can say at this time. Once they do that, then I'm sure they're going to probably move it forward. So the people who are starting this year, most likely, if they are in those 2 sites that they're going to pilot it, then they'll be able to do that. Now, the other question you asked, the question you would say, okay, how about those who are board certified, who already have been practicing in a particular area? So let's say you have a pharmacist who's gone through the fellowship and who has been doing, I'm just throwing it out now, maybe critical care for the past 3 years. All right. That individual and then the director for the board specialty is going to be able to talk to the group next month. That individual really qualifies to take the board certification exam in critical care, as long as there's evidence that they've been practicing in that area for 3 years plus, and that they're licensed pharmacists. See, so that's the other question you have, you know. So, and that's one of the reasons why your chairman wanted us to come and talk about board, you know, certification. Now, once you take the board certification, and you pass, then you're really a specialist in that field. All right. Now, the other question you ask is the fellowship for the West African College the same as residency? I think I've answered that. Quote unquote, it's probably the same, but there was something they were lacking: the pharmacy practice, the experiential exposure. That is all, that's what they needed. And I think going to this new phase of what they're going to be doing, whereby they're going to incorporate the ASHP standards, I think that's going to make that program more robust, and it will make it to what it needs to be. So the issue has always been the practice. And I tell everybody, you know, that if you take a pharmacist who trained in Nigeria and you put them beside a pharmacist who trained here in US, when it comes to didactic, I mean, the pharmacist in Nigeria beats us hands down. They're very strong. The opportunity has always been application of that knowledge. And that, in my opinion, has to do with the minimal exposure to practice. So I hope I've answered all your questions. So I think more to come on that. I'm sure you're going to be hearing more from the West African, but they do have good plans in terms of how they can kind of move their fellowship to the higher level. Yeah. So I hope that answers your question. Now, there are a few points I just want to make from the presentation today. I want to make the point that all pharmacists, irrespective of your area of practice, whether you're practicing in the community, which we call outpatient, or in the clinic, or in the hospital, we are clinical pharmacists. I want you all to continue to remember that. It's very, very important. Now, the issue is we just need to get the tools for the pharmacists to feel comfortable and confident to be able to start using their clinical skills. It's not only the tools to do that, but also the confidence to know how to communicate this to the other healthcare professionals, like the physicians, the nurses, the patients. You all have heard a lot today. You heard from the specialists who are practicing in acute care, which is Dr. Moye, Angela, and then you also heard from the specialist who's practicing in the ambulatory. Ambulatory is the same as community or clinic. It's the same, meaning it's not in the hospital. If you all listen very closely to what they said, they pretty much doing the same thing. I am practicing in the acute care, metabolic support service. Uche talked about collaborative practice for chronic disease management. I'm doing the same thing in the acute care when it comes to nutrition support. I'm considered a consultant. I write all the TPN orders. I manage electrolytes. So it's the same. So I'm just trying to get us to see the similarity. All pharmacists, whether in the hospital, whether you're in the community, we are all clinical pharmacists. So that's one thing, and please continue to remember that. So the issue is, I've answered the question about what are the skills you'll need to get to feel comfortable. You guys heard from the 3 specialists. In US, they had PharmD, they had residency, they had 1 and 2. Then they did board, they became board certified. One person, I think it was Miranda, asked, if you do the PGY1 in US, does that make you okay to practice as a clinical pharmacist? Now, here in US, to practice in hospital, they are requiring for you not only to have PharmD, but to have PGY1. In order to be a specialist, they require you have PGY2. But I want you all to also listen, see what happened, what's going on with Pam and Angela. I think somebody mentioned academia and acute care. What did I do in my hospital? In my hospital, I was the only specialist hired by the hospital. But I knew I wanted a robust residency program. I wanted a robust clinical pharmacy program. What did I do? I partnered with the School of Pharmacy. And I sold my site to the school to say, hey, bring your specialists here. They can use my site to train their students. In return, I want them to help me develop my pharmacist. So that's why you see Dr. Moye is one of my preceptors for my residency program. She also helps me do staff development for our pharmacists. So indirectly, what I've done is I have resources from the school, but we're not paying them. So I want you to really think about that and see how can you all learn from that. So the issue is collaboration with the school and the pharmacy department. That's what that is. Collaboration with the school and pharmacy department. You guys had examples from Uche, what she did, how she's promoting pharmacy, working with the doctors. I always tell people that pharmacists, we are the biggest politicians, but we don't know that. What is she doing? She's promoting her service. And sometimes you have to pick your fight, as long as the patient stays the focus. So that's another point I want to bring up, So think about how can you all utilize the pharmacy schools for those of you who are in the hospital. Even those of you who are in the community, you can develop a relationship with the school. You can say, have them partner so that they can do all those clinical services, work with you, and then the third thing is we need to start publication. You all had all the interventions that they were doing. We need all the interventions we do. We need to start promoting those interventions. That's how we show our value to everybody, So I think I would like to stop there. Those are just some key points I want to bring. And I hope, Dr. Maureen, that I answered your questions about the residency and the direction. And like I said, more is going to come on that. Yeah, there's somebody else that has their hand up. I think it's Kanu, Ifeoma Kanu.
Thank you so much, Dr. Pounds.
Yeah.
It's like somebody intimated me that #1 pharmacist in Nigeria is in our midst, but I checked the roll call, I cannot find him. Professor Cyril Usifo, or Denos Usifo, APSM president. Yeah. I don't know whether Prof is around. If Prof is around, Prof, can you give us some remarks before we go on some other questions and other appraisals?
Okay.
Our president, are you around, sir? Mr. President, His Excellency, are you on board? I don't think the president is on board. If he's not on board,
he's around. He's around. He's around. Yes.
Okay. Sorry.
He's around.
Sorry. So that I will not be taken to court. Mr. President, you can go ahead, sir.
I really want to appreciate all of us for staying up late, making sure that we give our best to the pharmacy profession. Like I discussed with my sister yesterday, Dr. Teresa Pound, a new dawn is happening in pharmacy. And like I told people at the PSN Secretariat, a new sheriff is in town, and we will do things differently. I won't say much, but it's of note that the first PharmD student, regular PharmD student, graduated under my watch as Dean. We will do everything to make sure that we promote clinical pharmacy. I must also not forget to commend the CPAN and her team, where myself and Professor Nato visited Mensa. We spent about a week and we learned quite a great deal of things. I want to believe that such opportunities will arise, such that clinical pharmacists, not just in academia alone, but in hospital and place of practice, will be able to exchange and cross-fertilize ideas with their counterparts in the United States. I will leave it there because we are presently formulating something that will help us to oversee what we are doing in Nigeria and the United States. May God continue to bless us. God bless pharmacists. God bless NAPSA. God bless PSN. And God bless Nigeria. Thank you very much. And CPAN particularly. Thank you.
Thank you so much, our #1 pharmacist in Nigeria. Thank you for that encouragement. You're always there. I know for some time you've shedded weight because on the journey to make pharmacy a better one. And we will get there in Jesus' name. The next on the line should be Dr. Margaret Afolabi. I don't know whether she's around because she raised her hands up before, whether she's around to comment or to ask questions or to appraise or any contributions. If Dr. Margaret Afolabi is not around, Dr. Nuhu Abdullahi M. Is he there? If Nuhu Abdullahi is not there, then we can go to Kano Ifoma. Kano Ifoma, are you there? Kano Ifoma, you're still, just doesn't mean you raise your hand and you're in the kitchen preparing some soup for your husband. Because it's possible, maybe one of your hand is up while you are there in the kitchen doing some other things. Because it's already, we are going to the 12th, is getting to 11 p.m. This is some minutes to 11 p.m. Okay. Dr. Margaret Afolabi is around now. Please, can you take it up from there?
Okay. Yes. Can you hear me?
We can hear you loud and clear.
Okay. Thank you very much. Professor Afolabi is the name.
Oh, sorry.
Dean of Pharmacy, Ife. I want to appreciate our speakers, particularly Dr. Pants, for the great contributions. I just want to point our attention to some of the core emphasis of our speakers with respect to collaboration among the different practice areas of pharmacy and also alongside with the doctors. Particularly our sister that talked about starting with the low-hanging fruits. I think it's essential for us to get in to actually see where we can be of great help towards optimizing patient care. And our areas of expertise, as have been mentioned, include medication reconciliation, drug information, patient education, and of course, monitoring adherence to medication by the patients. I think as pharmacists, if you can take advantage of this, and with my little interaction with the medics, you'll see that they're always willing to collaborate with us on projects. But I tend to see that this is the area where we are failing as practicing pharmacists in the hospital. And we tend to straitjacket our activities. The academics run their research, the hospital pharmacists do their dispensing. But for us coming together, getting the project, working on research together, you see that our three speakers, they kept on talking about collaboration, working on projects, and seeing how they can be of benefit, even in the practice. So this is just what I want us, the model I want us to take on, even as practicing pharmacists in Nigeria. And it's definitely going to encourage the impact we are going to make in the healthcare team. Thank you very much.
Very good.
Thank you so much, Professor Afolabi. Sorry, I called you Dr. Afolabi. Thank you so much, Prof. The point is that there is a lot of politics in the hospital practice in Nigeria. And just like as our Western siblings said, and they're about where things work well in the Western world, in the United States of America, in Nigeria, there are some things we need to extricate from ourselves the pride, the first graduation syndrome, the knowledge westering phenomenon, all those things we need to throw it away because we have to really accept that we need to do like US before we will be able to prepare to go to rooms. So we believe we'll get there. We will be able to surmount the politics and be able to move ahead. Thank you so much, Ma. The next person I can see his hand is Dr. Ademola Suleiman. I don't know whether he can talk.
I can talk, sir.
Okay, go ahead. Go ahead.
Good evening, everyone. But then it's good morning from here.
Okay.
I actually love my lecturer that just finished talking, Professor Afolabi. And I think one of the things that I want to beg of the PSN, especially the presidents and the deans of the faculties, is that the issue of collaboration will only be able to work out if it is institutionalized. If there is a space for community pharmacists in Faculty of Pharmacy in OAU, if there is a space for hospital or community pharmacy in OAU teaching hospital, I'm just using that as an example, you will know that it will be very easy because it's not as if the community pharmacy do not want to work in the university, but it is not institutionalized that we need 5, we need 10, we need 15. You can imagine here in Uganda, there is a recognized spaces for community pharmacists to come into the Faculty of Pharmacy to teach. There is the same thing for the academic pharmacy to also go to the hospital to also teach on the bedside. Not only to even teach the pharmacy students, even the medical students. I am here teaching pharmacotherapeutics to the nursing students, to the pharmacy students, and then also to the medical students. So my money is there. It is not, and the hospital have me as an adjunct staff in the hospital, and I'm a full staff in the university. So if it is institutionalized, it will be very easy. It will not be a thing of the OAU to do it or you are to do it, but then it is interrelationship. So you can apply, and then if your CV worth it, you will be employed as an adjunct, and then the whole thing will go. So I think the PCN and the PSN should actually move as an institution and then let this thing be institutionalized. Thank you very much and good morning.
Who is the last speaker? Who was that last speaker? What's his name?
Is it Professor
Ademola Suleiman?
Okay,
from
very good.
Islamic University in Uganda.
Oh, in Uganda. Okay. All right. Very good.
Yeah.
No, I like what you said.
I teach pharmacology in Uganda.
Okay. We can talk offline. I'll try to see if I can talk to you.
Thank you so much, Dr. Demola. You have to cut some for us.
Yeah, we'll talk offline. I thank you also, Professor Afolabi. I will talk offline with you also, Professor Afolabi.
Okay, thank you very much.
You cut some for us. When we finish, we'll call it a cut for Nigeria. It's a good one. So my IPCC is here. She wants to say something. Dr. Timipre OA. Dr. Timipre, please. Dr. Timmy. Dr. Timmy, are you there? Okay, Dr. Akakpo Abiodun, are you there? Akakpo Abiodun, are you there?
Yes, pharmacist Akakpo Abiodun.
Please.
Yeah, good evening, everyone. I'm so happy that I'm on this program this night. So enlightening. I want to appreciate all our guest speakers. God bless you so much. Yeah, here in Nigeria, there's a challenge that has been a thing that will be difficult to surmount. Number one, we still practice window dispensing. Difficult for us to assess patients as regard their medication use, medicine reconciliation, and to track drug-related problem. So if anything that Dr. Pamela and his team can do for us, such that window dispensing will be a thing of the past in Nigeria. It will be easy for us to touch our patients and make impact in their lives. Thank you.
Thank you so much, Pharmacist Akapo Abiodun. Well, hello.
I'm ready, Dr. Solomon.
Dr. Timmy, are you around?
Yes, I am.
Okay, please, I'll quickly call you. Let me just finish from Akapo Abiodun, because we cannot keep giving so much weight to our Western counterparts.
Yeah.
The issue of them helping us to close window dispensing, I don't think is within their powers, but within the powers of us. It is we. If we say we can't dispense through the window, nobody will kill us.
Yeah.
Nobody, I say it, nobody, no physician. This is what we want to do, and we do it. Please, let's not, I'm so sorry to use the word being petty. They cannot, Dr. Pans, Dr. This cannot do everything for us. Thank you so much. Dr. Timmy, please, can you come on board?
Yeah. Good evening, everybody. Thank you so much for this wonderful and very, very enlightening presentation tonight. In fact, it has just really opened our eyes. It's very, very interesting. Thank you so much. I want to find out, honestly, I want to know, because I know that the physicians, when they are done with their own program, the hospital actually, appoint them to become consultants. So I am actually directing this question to our mother here, Dr. Teresa Pound. Please, I want to find out, how is it done over there? Because some of us that have been done with, West Africa, long time ago, up till now, we know we call ourselves consultants. But actually, the hospital does not really recognize us as such. But our physicians, counterparts, they have been appointed. So I want to find out if really over there too, do they actually appoint them too? Do they, because I heard you say that you are a consultant. So I want to know, how is it done over there? Thank you, ma.
Yeah, thank you. I think I use the consultant actually used as a clinical specialist. So I'm actually a clinical specialist in nutrition support. And I have a metabolic support service whereby using collaborative practice agreement, I'm looked upon as a consultant to manage all patients who require parenteral nutrition support. So I manage their electrolytes, their nutrition and all that. And I think you can also see that in the outpatient basis, whereby you're using collaborative practice agreement to manage certain chronic disease states. I think in Nigeria, like you said, most of you are fellows of the West African program. I think it's probably not a bad idea to look at what is actually the definition for the consultant in Nigeria. What exactly, and that may be another topic for another day, because I gave a presentation, I believe it was last year, to this group, whereby we looked at, I looked at the whole thing. I'm still saying that in order to say you're a consultant in whichever way you want to look at it, you have to be comfortable clinically in that area that you are the specialist. I think what I'm trying to say is that you have to become a specialist in a particular clinical area. For example, critical care, oncology, cardiology, in the ambulatory care setting. You have to be a specialist. And in order to be a specialist, you have to have that knowledge base and that comfort level to be able to say, to be able to go work with the physicians and support them when it comes to medication therapy management. I think we may want to make a note of this and say, maybe look at it at some other point, another time, because that's really a whole lot of this. So in Nigeria, in US, when you finish your PGY1 and your PGY1, you can practice as a clinical pharmacist, meaning you are a general. If you do PGY2, maybe in cardiology, then you're a specialist in cardiology. That means you are rounding with the cardiologists. You are the one they will look at if there's like a research in cardiology, if they have to teach the students. So you're viewed as a specialist when it comes to medication therapy management. That's the way it is in US. Now, obviously, when you're hired as a specialist, you get more pay. So you paid more than somebody who is a clinical pharmacist because you have more training. So I think we have to look at how you guys want to make that happen, or look at what it's going to look like in Nigeria. So, and I can talk offline with you. Please, by all means, and please share our information with everybody. You can call, we can discuss more. But I will tell you that as president of NAPSA, just like your president, Professor Cyril Sufo said, this is one of the areas that I've really taken on that I want to make happen during my tenure. I want to have, we're looking at how we can collaborate with the pharmacists in different areas and address some of these issues. So more to come on that. We have a plan for that. Yeah. And I hope I'm giving you a little taste of your question. Yeah.
Is it okay?
Point of
is it okay?
information.
This is Dr. Nuese. Is it okay if we address the pharmacist that asked about window dispensing? I just want to briefly answer his question. I know that a lot of us have moved on, and so the issue of window pharmacy, I saw somebody say in the chat, is that still happening? My thoughts are, even though we have done away with window dispensing in a lot of places, we still, in our mindset, still practice as window pharmacists. And because we're not looking beyond dispensing. If you're still looking at, just dispensing, then you're still practicing as a window pharmacist, even though the door has been broken open by maybe our predecessors. What I want to say to the pharmacists is this: if you can, start with patient education. Patients ought to know that when they come to the pharmacy, bring your medications. Patient ought to know how to know which medications they are taking. Start with patient education. I speak out of experience. I worked in JOS for a little bit at the Heart to Heart Center where we were dispensing HIV medications. And so what we did was, we didn't have electronic medical records. We didn't have a lot of clinical platform. What we did was teach patients, to, number one, bring their medicines anytime they're coming to the pharmacy. Number two, start learning the names of your medication or maintain a medication list. That way, and if that is the one thing you accomplish in your year one, like, okay, this is my 3-year or 4-year development plan. In first year, we know we want to do medication reconciliation, but we don't know what the patients are taking. Let's start with this year by educating patients. Number one, when they come to the clinic or to the pharmacy, bring your medication list, or educating them on the names of their medicine. I think we should look at the problem and assess where the problem is and start tackling it bit by bit. That's my thank you very much.
Yeah. Thank you, Uche. And I know there are a lot of questions, and I know it's probably getting late. What I would suggest is you can just send the questions. You can do it by email, send it to me. I'll make sure it goes to the respective person. You know what I'm saying? Because this is a very hot topic, but I would like to close really by saying that we are here to support you. As president of NAPSA, I think you're going to be hearing more. Feel free to call me, and if anybody has any burning questions, because there are a lot of opportunities here I see here. We can look at the model of teaming up with the pharmacy school. We can look at getting, just some of the information that has been shared. But I think there's quite some more work to be done that we have to do offline, and whatever it takes, I will work with the chairman, Dr. Madu, with the PSM president, or if you have like the head of the pharmacy department, that, just let me know. In fact, we have what we call the diaspora initiative that is also going to be starting And I don't know, is anybody here from Enugu, the teaching hospital in Enugu? I think there are 3 pilot areas: teaching hospital in Enugu, university, the teaching hospital in Benin, and then the national hospital in Abuja, whereby we've asked them to identify training needs, and whereby the physicians, pharmacists, and nurses, we're going to be doing some skills transfer, really addressing of these issues. So I think we just have to keep working at it to, but please, all the questions, comments, people that we're not able to address today, we definitely want to hear about it. All right. So
thank you so much, Ma. Thank you. Actually, you've actually said it because I really wanted to round up because it's already late. You've done the vote of thanks, so there is no need again. The only thing we have to do is to call on our national secretary CPAN to lead us in closing prayer. I don't know whether she's around.
Okay.
Dr. Motihat, are you around? If Dr. Motihat is not around, then the National Assistant Secretary will take the responsibility.
I'm around.
Okay, ma. Sorry, ma.
I'm around.
Right.
Good evening, everyone.
Good evening.
It has been a very, very interesting session. Well done, Maz. It's been a very, very interesting session. I was just typing on the group before I take the closing prayer. I'm saying that if you have people here that are not members yet and
okay.
Go ahead,
to join, they can contact us. Closing prayer. We particularly thank him. We beseech him to please come and assist us as we seek to make the model for others to the United States where they are today. And we pray this will happen soon in our lifetime.
Amen.
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 Thank you, Dr. Pans. Thank you, everybody. Good night.
Amen. Thank you. Good night.
Thank you, everyone. Thank you, everyone.
Thank you.
Presenters.
Thank you,
ma'am.
Nice. Thank you.
Good night.
Thank you. That was beautiful. Thank you. Good
Yes,
night.
it was
Thank you,
beautiful.
everyone.
Good night.
Thank you.
Night.
Thank you. Good night.
Night.
Thank
you, everyone. Good night.
Thank you very much for having us.
Night.
Thank you. Excellent presentation.
Very
Good
much.
night.
Thank you. Thank you, everyone.
Bye, everyone.